Good afternoon, everyone. Thanks for coming over for the last session of the day. I am told my co-chair, Dr. Anton Wokheim, is not here, so we are going to start the session now. I was thinking of waiting for him, but I believe he's not here. So never mind. We have a very interesting session on update on BPD, and it's a pleasure to have Dr. Wes Olin from Amsterdam to talk on, and he has two talks to give back to back, so I hope he'll be coping with that. The first talk is on definitions and pathophysiology. Why haven't we got it right yet? So the floor is yours, Wes.
Thank you very much. Thank you very much, Dr. Gupta. Thanks for sticking around. I'm not sure if it's a wise thing to dim the light this much because it's a long day, but I'm going to try to keep you awake. I have changed my title a little bit because I'm going to talk only a little bit about pathophysiology. In 20 minutes and talking why BPD is happening, that's too short. But I am going to talk a lot about the definitions of BPD because we have a problem. It's not an honor to be here. It's literally a dream. Since I have been 15, I have been dreaming of the jazz festival of the Montreux, live at Montreux. And since then, I've been collecting together with my brother all the CDs, compact discs from the past, from that beautiful jazz festival. And I have an urgent request to the organizing committee. Please either ask the jazz festival to move forwards directly after the festival or move the conference directly before, because now I have to come back at 1.5 months to come to the jazz festival. All right, and maybe next year we can join each other in another festival and play some music. Maybe the band of me and my brother is the bald one on the right with the big horn, we can play and make you dance instead of sitting here in a room, in a dark room. All right, that having said, I'm going to talk about the old versus the new BPD, and I think most of you know this stuff. I'm going to show you that there is a problem with the BPD rate over time. And then the mayhem, the chaos of the BPD definition currently is going to be displayed. And then I'm going to ask you for your help. I'm not going to ask you to come over here and sing a song on this stage with me, but I'm going to ask you for your help if you have an opinion about the BPD definition. And then finally, I will make my conclusions. First, the old versus the new BPD, or the classic form of BPD versus the new BPD. It all started more than 50 years ago with this publication of Dr. Northway describing a form of chronic lung disease in preterm infants. But as we all know, and nicely depicted here in this article of Boraldi et al., those children published in 1967 are a different kind of infants we're seeing now in our units, because these were infants that were born in the alveolar stage. Rather old preterm infants with developed lungs, and they didn't know how to treat these babies well. They didn't have any surfactant or any antenatal steroids, so they had a rather damaged lung pattern. But what did they say? They saw a clinical pattern of prolonged respiratory support and a long supplemental oxygen and severe tachy and dyspnoic infants. On the X-ray, they saw severe morphological aberrations, large atelectasis and fibrosis of those children. And histology, they saw the fibrosis was apparently in those histology preparations. At that time, the definition was a diagnosis at 28 days of postnatal age. But since then, the neonatology care has been improved. How did we do that? By antenatal steroids, by the introduction of surfactant, and most importantly, by less aggressive invasive ventilation. That meant that more preterm infants were surviving at younger ages, so also at a younger lung developmental stage, about 24 to 32 weeks, in the secular stage. And that means that there are different patterns of BPD. They had shorter periods of ventilation, less pressure, less supplemental oxygen, and in the radiology there's a marked difference I'm going to show you in the next slide. There is a reduced lung volume, but less interstitial densities. You can see it. On the right side you see the new BPD, and on the left side the classical BPD. And there's a marked difference between those two infants. On histology, you see here a rather normal development of the lung, with a nice thin layer of pneumocytes. But when you look at the classical form of BPD, you see large spaces and a large form of fibrosis. Compared to the new BPD, where you have less fibrosis, but the air spaces are still really tight. Seeing these differences, it's not damaging the lung anymore, but it's not able to let them grow and to be grow sufficient secondary septae. What did BPD incidence over time do? First, some good news. Namely, that mortality over time is decreasing. In the upper figure, it is survival. And as you can see in the USA, there's a large study, cohort study, displaying different gestational ages. You see over time an increased survival. And the other two are mortality. So they are just the other way around. And as you can see, the mortality in Japan over time between 2003 and 2016 is decreasing. And the European and Canadian networks also showing their survival as more or less the same picture. So that's the good news. We have more infants surviving at different gestational ages. But how about BPD then? Well, that's less positive news, because the BPD is either staying exactly the same or even increasing. And that is in the USA, going from 30% to 40%, or Japan, where we have a median of 40% going up to 60%. And in the European trials, networks and Canadian network, there's either a no difference over time or an increase. So we're not making any progress when you look at these figures. BPD definition and the diagnosis over time started, as I showed, in the 1970s. But with the increasing survival of the more preterm infants, in 1988, 2001, they said, well, maybe the 28 days postnatal age of diagnosis is not sufficient anymore. We have to refigure how to define BPD. So in 2001, there was an international workshop where all the scholars and all the clinicians came together, and they came up with a definition called the Joe Bancalari definition, or the NIH 2001 definition. What they came up with, and it was really a doctor-based approach. Namely that you had to have more than 21% of oxygen for more than 28 days. And that's not cumulative. That is, you could start with 21%, but on the course of staying in your NICU, if it was more than 28 days, you had your mark of BPD. And then you had to look at 36 weeks of postmenstrual age. And when you had the criteria of more than 28 days, more than 21% of oxygen, then you had to define the severity of the BPD into mild, moderate, or severe BPD. Mild being on room air or no respiratory support. That's the difference between the States and Europe. Sometimes we give a nasal cannula with 1 liter, 21%, just to support the child a little bit, but it's still mild BPD. But when you're on nasal cannula with more than 21% to 30%, you are on moderate BPD. And severe BPD is either you have a higher supplemental oxygen or positive pressure, either CPP or on mechanical ventilation. Having this definition, that's a bad thing. Ah, there it is. Having this definition was, after 3 years, Dr. Walsh came with an extra test, the oxygen reduction test. Because we are using oxygen for more than just the lungs. She showed it in a trial where she divided the old definition according to the Joe Bancalari criteria, and did a oxygen reduction test. And as you can see here on the black bars compared to the gray bars, some centers, because that's the figures 1 to 17, some centers did not show many differences, but there were also, when you look at numbers 14, a lot of centers that had a big difference between the old definition and the physiological definition. How is that? Well, we did at that time some oxygen reduction tests, and this is one of them. This is the child, 36 weeks, had 28 days of supplemental oxygen, and was on a nasal cannula 1 liter with 30% of oxygen. And we did a reduction test, and this is what you show them. You reduce the amount of oxygen, and eventually he goes below a threshold of 80. And then you stop the test, and then you say, okay, this child has a moderate form of BPD. But a couple of weeks later, other child, same respiratory support, 30%, 1 liter, and you reduce the oxygen, and then nothing happens. The nasal cannula are removed from the face, and he still stays approximately above 90%. This child doesn't have any supplemental oxygen because of the lung damage. But why then? Well, because of this pattern, periodic breathing. Sometimes we give oxygen because of periodic breathing. That's not the same as BPD. So this child has been marked as a mild BPD. Another reason, an important reason, is because sometimes the eye doctor are telling us to give extras just to prevent pre-threshold RP. I'm not going to into what the evidence is about that particular therapeutic intervention, but that's also a reason why sometimes infants get more oxygen than for the BPD definition is needed. So when we go back to the timeline, there was a rather peaceful period between 2004 and, well, say approximately 6 years ago. There you had the Bancalari-Jobe definition with the oxygen reduction test, and that's what we were doing. But then the international discussion was upon us, because we were asking ourselves, what is the correlation between the BPD diagnosis and the long-term follow-up, not only on the neurocognitive outcome, but also on the respiratory morbidity. And, well, some of us had really difficulties counting the cumulative days of supplemental oxygen, because you had, every day, you had to mark in the chart of the patient whether the child had a day of oxygen or not. And the Vermont Oxford Network came up with a solution, but by saying, okay, you don't have to count all 28 days or during the admission of the infant, but just look at 28 days postnatal age. When the child is then having a supplemental oxygen, then the first criteria for BPD has been fulfilled. During that period, between 2004 and later on, recently, new modalities came up, high flow nasal cannula. And how do we incorporate that in the definition? Well, to be short, there was a lot of discussion and a lot of publications. And one of them, a landmark paper for me, was this paper from Dr. Heinz, who did a systematic research and looked up all the BPD definitions used in the papers. 820 papers were identified. And what's surprisingly is that almost one-fourth didn't mention what definition they were using and how they were assessing the BPD definition. He looked into all these papers and looked specifically at those papers who were validating different BPD diagnoses. And as you can see here, as an example of all these, is that the BPD incidence, when you're using different diagnoses, changes dramatically. He looked at a validation paper of Ehrenkrantz, published in 2005, a large cohort who, and he looked at different BPD diagnoses, Thule with the X-rays, Shannon with the X-rays, and NICHD. And which, as you can see, is the BPD differences between these diagnoses differ from 40 to 77%. Then, and at 2017, immediately after the paper, the Canadian network came with this paper with a validation study on BPD definitions. They took their network cohort between 2010 and 2011, and they validated what was the best definition. 28 days, 36 weeks, only supplemental or a combination of your modality of respiratory support and of supplemental oxygen. And what outcome was best predictive, the discriminating accuracy for respiratory morbidity or long-term follow-up, neurocognitive. And what they showed is that when you had to choose between all the different modalities, including supplemental oxygen or not, is that the combination of respiratory support and supplemental oxygen gives the optimal predictive accuracy. However, what they also found is that when you postpone your severity assessment to 39 to 40 weeks, it even increased even more. So they pose the question, should we not assess the BPD definition at 40 weeks instead of 36 weeks? Then the following publication was that of the NIH at 2018. Again, they held a workshop and they revisited the BPD definition. And they said, okay, maybe the 28 days of supplemental oxygen is too difficult to assess. Let's get rid of that one. They incorporated the high flow nasal cannula and the CPAP, and they added a new extra grade, the grade 3A, where they defined the mortality due to respiratory insufficiency likely to become BPD, which is rather a difficult diagnosis, of course. And then part 3 is, a year later, is Jensen, who made a evidence-based approach to looking at a optimal BPD definition. He used a large cohort and made 18 diagnostic models predicting respiratory morbidity and NDI at 2 years. And he calculated the predictive accuracy of all those models. And what he finally concluded was that the best performing optimal diagnostic criteria were only the use of nasal cannular flow, less or more than 2 liters, with non-invasive CPAP, and then finally a grade 3 was those infants who were on invasive mechanical ventilation, all at 36 weeks postmenstrual age. What we did is we compared these definitions in our own cohort, because since 2009 we have been collecting all respiratory flows, CPAP, FiO2s of all the infants in our NICU. And what we saw when we compared those 3 definitions, namely the 2001 NIH definition, the 2018 NIH, and the Jensen definition on both 2-year and 5 years neurodevelopmental outcome, there's no differences between these 3 definitions. All these definitions have the same predictive accuracy. And then finally, which makes probably, when you think of it, the most sense, should we not get rid of all the doctor-based definitions, where the doctor determines what kind of BPD you're having, and should we go to a physiological definition? So Benjamin Sucklin, together with Jane Pillow, came up with a rather pathophysiological method of determining BPD. I think the main problem is that you have to put some effort into this to establish whether a child has BPD or not. And the big question is, are we willing to give that time, to spend that time? So here's the summary of the timeline of the BPD diagnosis over time, and also showing that there's a chaos of different definitions. And there are publications saying, well, maybe we should discuss and pick one, but which one then? Well, that's where my conclusions come, and then I'm going to tell you where we have to go from here. What we know is that we have an increased survival. That's a good thing. But we also have an increased or the same amount of BPD. We're not managing the babies long-wise the best way we can. However, the reported BPD incidence varies, and you have to bear in mind that these different definitions also mean that they are reclassification of the severity of BPD. So when you have severe BPD in the Bancalari, it doesn't mean that you have severe BPD in the Jensen definition. So we can't compare BPD definitions with each other. New definitions have the advantage that they incorporate the new modalities, and they are sufficient in predicting the outcome, respiratory and neurocognitive outcome, as shown by Jensen et al. But we don't have any consensus on which definition to use. So where do we come from here? And this is where you come in. We need to increase our uniformity. We need to figure out why do we want to need for a BPD definition. For what purpose do we use it? Are we using it for the clinical trials? Are we using it for the benchmarking? Or are we using it for the parents? And it might even be that we end up using more than one definition for the different purposes. But the condition we have to strive to is that it's going to be global. We're going to have to do it all the same. And it has to be generalizable. For instance, in the Netherlands, we have a referral-based health system where preterm infants are treated in the NICU when they're below 30 weeks of age. But when they're growing and they're above 38, we are transferring them to a local hospital where there are not much time to assess or do a complicated assessment of BPD diagnosis. So to see what people want and how much time they want to put into it, we are recruiting people for a Delphi procedure. Together, we have been contacting all authors who had something to do with a BPD definition, Dr. Bancalari, Dr. Higgins, and Dr. Jensen from the States, Dr. Ishiyama from Canada and now currently in Japan, and Dr. Prakash and Dr. Offringa from Canada, James Pillow from Australia, and the local hero, Benjamin Stocklin from Swiss, who was working with James Pillow on the pathophysiological definition. And together with this team, we have been making a Delphi procedure survey, which we want to send out throughout the whole world. And the research question of this Delphi procedure is, what are the key drivers for you and the researchers regarding a BPD definition? The ease of use, time point, are we willing to do an oxygen reduction test, but it should be with sufficient predictive performances. And which outcome are we striving to, a respiratory outcome or neurodevelopmental outcome? And I would like to emphasize that with this Delphi procedure, we're not aiming to choose a BPD definition and choose one above the other. Now we're just wanting to make a landscape of what are we using the BPD definition for. What we'd like to have is a representation of all countries and all continents, and also multidisciplinary. So with neonatologists, but also pulmonologists, respiratory therapists and ventilation practitioners, and of course researchers. What is the Delphi procedure? It is nothing more, nothing less than a survey with a structured communication technique or method which relies on a panel of experts. And the first question is, am I an expert? Well, when you're working with preterm infants and you sometimes use the word BPD, yes, then you're an expert. What is the Delphi procedure further is that it is a guaranteed anonymity of the participants. And it goes in several rounds. So it's a structured information flow with a regular feedback. We're going to do a first survey. We're going to analyze that and give it back to for a second round to show you what the results of the first round is. And we have, of course, a objective regulator, which is not a neonatologist, but a gynecologist, nothing to do with BPD, to ensure objectivity on the whole process. What is it? It is an open link survey in Castor, and we're aiming for 2 rounds, but maybe we need an extra round if we need more consensus in the answers we're getting. And afterwards, we are planning an online meeting or a physical meeting to discuss the results. Hopefully, this is a starting point where we can discuss what to do with the chaos in the BPD definition. How much time are we asking from you? Well, not much. If you want to participate, if you have an opinion and you work with infants with BPD, contact us. What is going to take your time? About 15 to 20 minutes per round. And as I said, we're aiming for 2 rounds. Maybe a 3rd round is needed if there's no consensus. There's not much time. What's the summary of this talk? Well, that BPD, it is here to stay, unfortunately. That there are a lot of definitions published, and I'm not sure about you, but whenever I submit an article, one of the first questions, if I'm using the definition of Jensen, they're asking why didn't you use the Bancalari definition, and vice versa. Let's get rid of that. We don't have any evidence of superiority. So a sentence in an article I read was, the one definition to rule them all is a nice one, but I don't think that is going to happen. So we have to choose. The Delphi procedure has been started, and the steering committee you saw is disseminating and sending all emails as we speak. Like I said, the objective is not to get a new definition, but to increase the BPD definition uniformity assessment and start a structured discussion. Thank you very much. Open for that.
Thank you very much, Wes. Excellent talk, and I think you have really nicely covered the genesis of the BPD definitions over the last approximately 50 years. The time is not left for any questions, but are you okay to go on with the next talk? The next talk is the prevention and prediction of BPD. The floor is yours. I'm slightly conscious of the time, just because after this session, I think people will have to be rushing back. So let's carry on. Thank you.
I'll talk fast. Because, again, like the previous talk, talking in 20 minutes about the treatment of BPD is impossible. So I'm only going to scratch the treatment part and then go on to the prediction. But first, I'm going to show you a picture of my unit. This is Amsterdam, when I started as a young fellow. And as you can see, it's a cubicle, and it's covered with large sensormatics, invasive ventilation devices. And the next month, we're going to open our brand new renovated unit. And as you can see, it's a single bed unit, but there's also a very other difference. The ventilators are gone. And that's because of the emphasis I would like to make is that not ventilating is essential in preventing BPD. Like I said, the bad news is that BPD is here to stay. We've covered that, so we still have a problem. And I would like to share you some old news briefly, because the progress in the treatment of BPD is also going very, very slow. Most of the things we know about treating BPD is what we already knew 10 years ago. And more recently is more avoiding lung damage. But then the main topic of this talk is going to be the prediction of BPD. Why do we want to predict BPD? And what's the evidence of the prediction models? And I'm going to show you something. What we're doing in Amsterdam, we smell our patients. Yes, we sniffle at our patients. I'm going to show you. First, the evidence, like I said, and this is a publication, as you can see, already in 2008 by Barbara Smith. And yes, there are a few changes, but the main interventions are displayed here: caffeine, vitamin A, and corticosteroids. And so the past 15 years, there's not been many progress in preventing BPD, except that what we all know is that thou shalt not ventilate. There are no high-quality randomized controlled trials comparing a lot of ventilation versus less ventilation, but cohort studies have shown us that it reduces BPD. It reduces BPD and death. The one thing we didn't know is that even if you try to prevent BPD or prevent death, does it also benefit long-term outcome? Does it benefit the pulmonary outcome in childhood, but especially the neurodevelopmental outcome? And that's a study we did and published in 2017, where we compared two cohorts in 2005 and 2011 in our units. And we looked at, because at that time we really went from already pretty restrictive ventilation now purely restrictive ventilation. And we looked at the BPD diagnosis, but also at the 2 years corrected age neurodevelopmental outcomes. And it's probably a little bit small, but here you can see the difference between the two epochs. In 2005, in the delivery room, we intubated approximately 1/3 of the patients, while 6 years later, it was only 10%, 1 in 10. And even now we have Lisa, it's going to be 5% something that we intubate in our delivery room. And these are all infants below 30 weeks. And the same applies for the duration of mechanical ventilation, where you see a decrease of duration in days. but also the mean duration per episode of mechanical ventilation. It decreases between the two epochs. So yes, we have been able to, it is feasible to really be restrictive in your ventilation. But what does it do on your neurodevelopmental outcome? Because we were a little bit afraid that sometimes the pendulum swings the other way around. By trying to prevent BPD, didn't we induce more prolonged episodes of hypoxia and thus inducing a neurodevelopmental outcome? Well, these figures show the other way around. Namely that by doing a restrictive ventilation, you have a reduced risk of neurodevelopmental impairment at 2 years corrected age. So that's comforting. What is more on the evidence on the internet as well? One is the intubation versus CPAP, and this is probably known by you all, is that the randomized controlled trials nicely put together in a systematic review by Schmelzer et al. Showed that there is an a decreased risk of death and BPD at 36 weeks when you're not intubating on the delivery room or the operation room. And the other one that's been upcoming, and we have been doing LISA for about, well, I think 10 years now. It is feasible, and it shows by all the randomized controlled trials that it decreases the risk of BPD and also the death and BPD with a number needed to treat of 15. So LISA is one thing that is a common practice in our ward now. The one thing we're discussing about is doxapram, because doxapram is for breathing control system, is something that in Europe and in the Netherlands we used a lot, and it is not used in the USA. There's a big difference. Why is that? Well, there's a systematic review in 2016 that showed very low quality or no evidence at all. And when you do a cohort study, doxapram versus no treatment, you see that there's and you look at the long-term neurodevelopmental outcome, you see that compared to non-treatment, the infants on doxapram have a decreased risk of neurodevelopmental impairment. But again, this is a cohort study and not a randomized controlled trial. So the quality of the evidence is low. A large multi-center randomized controlled trial is needed and is currently recruiting in the Netherlands. With this trial, we hope to show that doxapram is not only feasible in decreasing the need for a mechanical ventilation, but also that it is safe on the neurodevelopmental outcome. All right, let's move on then to prediction of BPD. Why do you want to predict BPD? Well, maybe because you want to use it in your clinical practice to set a prognosis for parents or to start an early treatment to prevent problems with the BPD. But as a trialist, I think it's more important that we are going to use prediction models, because are we targeting the right patients in our trials? Because when you're including a patient that's not going to have a BPD, either you put them in a trial or not, then you have a regression to your mean of your efficacy, and then you have a higher number needed to treat in your trial. On the other way around, with the history of the steroids in mind, you do not want to include a patient that will not have BPD in the end, but to a trial that might have a adverse effect. So targeting the right patients is essential for doing trials. For me personally, this is the reason why I want to have a prediction model. This is a matrix regression analysis performed by Doyle et al. published in 2014, where he looked at all the randomized controlled trials, and he did a meta-regression displaying the trials on the number of the percentage of BPD in the placebo group, and then looked at the effect estimate. And what he showed is that when you have a low rate of BPD in a control group, then you shouldn't give the steroids. However, if you have a high risk of BPD, as shown by the rate of BPD in a control group, then corticosteroids improves your long-term outcome. So what we need is a prediction model that accurately predicts a high risk of BPD. And for that, we need to do research and follow the following 5 steps when you want to implement a prediction model. First, you have to develop a prediction model. Then you have to do an internal validation, followed by external validation, and impact analysis. And after that, you can implement the prediction model in your trial or in your daily practice. And usually, we stop after internal validation. The last steps we do not do. Such a prediction model should be easy to use, bedside, and definitely not a difficult lab test to be used. It should have a high discriminating power, but also a good calibration. And those are 2 different things I'm going to show you. And like I said, you need to do 5 steps. And the first is the internal versus external validation. This is a slide showing the prediction models for BPD, published in 2013. And on the first column, you see the internal area under the curve. And there you see a high discriminating performances. But as we all know, is that you have a overfitting problem when you have only internal validation. That's why you need a external validation, because then you see the validation, the discriminating accuracy drop to very low figures. As you all know, 0.5 is the same as flip a coin. Calibration is something different than the discriminating accuracy. The calibration is something that says about the risk classification from low to high risks, and a prediction model should predict the outcome properly when you have a high risk, but also when you have a low risk. And as you can see here, this is not a very well calibration model. What is the evidence of the prediction models? Well, like I said, we did a systematic review in 2013 with a devastating result, because not only the methodological methods of the papers was not good, also not the discriminating performances of the models was not sufficient. We repeated this, and at the first side of this, in 2000, it's just been published. I was really disappointed because the methodological issues are still there. We identified 65 studies with a lot of derivation models and even more externally validated models. The good news is that we are getting better in predicting, so the accuracy is increasing, even after the external validation. It could be better, 0.77, but it is sufficient. However, the problem is that there's still a high risk of bias in the methodological domains, and especially in the analysis domain, as showed here. We're using small sample sizes, we're not mentioning missing values, and the calibration plots are not mentioned or not accurately calculated. And sometimes the models only select the high-risk populations, which is the ventilated infants only. And you want to predict BPD for your whole population. Although we have more satisfactory accuracy in the models, we need to be aware and improve our methodological issues in those models. And instead of developing yet another prediction model, we should update the ones we know now and improve them and use the proper methodology. And I'm not aware of any impact studies yet assessing what happens if you use a prediction model for BPD, not in an RCT and not in clinical practice. It would be very interesting to conduct such a study. I'm going to skip the biomarkers, and I'm going to show you something new. Because, like I said, in the Netherlands, we smell. We smell our patients. And it all started with a dog who could smell in the waiting room Clostridium, but also a publication, and that's an English cat, Oscar the cat, who could smell in a nursing home where the people were going to die in the next 24 hours. So, and that's all because we exhale volatile organic compounds, and we can analyze that. So the food industry is using it, even the army is using it and building it into their suits, detecting explosive in the neighborhood. Adults are more advanced in this technique than we are, but it's easy because adults can exhale breath more easily, but they're able to detect pneumonia, RDS, asthma, and COPD. And even therapeutic resistant asthma is being detected by exhaled breath. And since BPD is mainly an inflammatory disease, we thought, well, maybe we could detect BPD as well. So what we did is we performed a study between 2017 and 2019, all preterm infants, and the outcomes, of course, moderate and severe BPD, according to the Bancalari definition. And what we did, we collected exhaled breath at day 3 and day 7 of life, non-invasive or invasive ventilated support. And what you do is you analyze the different VOC compounds, you put them together, make them into a exhaled breath profile, and then calculate the ROC curve. And we incorporated them into a clinical prediction bell. There's a clinical prediction bell, NICHD, which includes birth weight, gestational age, respiratory support, FI2, and sex. And we added the VOC model to that NICHD to show you the added value of the VOCs according to your clinical model. We included 130 infants, and as you can see, between the BPD and no BPD infants, there is a difference in gestational age. So what the clinical model shows is a predictive accuracy of fairly of 0.83, which is rather nice. But adding the VOCs, you get a very, very nice discriminating accuracy of 0.92. That's day 3. And day 7, you see exactly the same pattern. And these are all, the major part of these infants are on non-invasive support. Calibration is good when you look at the high risks, which has a nice straight line in the high risk area, and less in the low risk. But when you want to use it to try to predict BPD for giving steroids, you only want to target high-risk patients. So that the calibration is nice in the high risk is a good thing. So what we're trying to do is perform an external validation study in the Netherlands, because this shows that identification of infants using VOCs is feasible, and that adding it to a clinical model improves the discriminating accuracy. It is non-invasive, and it is always available. That's why it's attractive to pursue this diagnostic method. And we are in need of an external validation, and we're currently recruiting. And then once we have that, we have to get it into a bedside tool, where you can plug in an electrode nose into the incubator. But it all starts with Which definition are we going to use? Within the time?
That was excellent. We have time for a couple of questions or comments. While people are thinking, may I just ask you, in terms of developing the definition of BPD and so, we have never integrated with the hemodynamics because they are quite correlated to each other. Because there's a degree of pulmonary hypertension with the ongoing BPD developing, which is always there, and the oxygen dependence will also depend on it. So in the new BPD classification, as you are working in the Delphi procedure, are you looking into integrating that aspect as well?
Like I said in my talk, we're not trying to get a new BPD definition. What you're asking is if there are different phenotypes of BPD, one with a more lung parenchyma, one more vascular, probably. But we're trying to simplify it instead of trying to make it more difficult for people to assess. Okay. So first we're going to try what do people want making the BPD definition. Difficult or less difficult?
Okay, thank you. Please.
Hi, Karma Mechelen from Maastricht. Thank you for your presentation, also the overview of the definitions. I was wondering, and I don't know if it's usual to do in Delphi methods, but maybe you did it. Did you ask parents what they find clinical relevant outcomes, and maybe we can use them in the definitions?
We have been discussing, because the Delphi is currently recruiting, so I don't have the results of the Delphi yet. We have been discussing a lot in the steering committee about involving nurses and also parents. And also with, we've been discussing it with an expert on Delphi procedure. But this is not about establishing a core outcome set. If you want to establish a core outcome set, then you should involve parents. But this is a medical diagnosis. This is something that the ones who are making the diagnosis should be involved. That's why we have left out the nurses and the parents in this Delphi procedure.
Okay, thank you.
Yeah.
Thank you very much for back-to-back talks. Thank you. I'm pleased to invite our next speaker, Professor Jenny Chong, who is neonatal pediatrician based at the Royal Women's Hospital in Melbourne. And she has obviously a lot of work done on the long-term outcomes of the high-risk infants. Today she's going to be talking on the effects on long-term development in babies with BPD, I believe. The floor is yours.
Thank you very much, and thank you to the organizers for the invitation to join you at this meeting today. It is past 5 o'clock, and I promise you there are no slides on physiology. But there is a slide on BPD. So I've been charged with talking about what the outcomes are for babies who have BPD beyond the neonatal nursery. So as we know BPD, and you've heard that in many talks, including Dr. Onland's talk just then, that it remains a significant challenge for neonatal care. The reason why I put up this slide wasn't to show you the histology or the radiology, but just to remind you that BPD does have permanent changes to the lung, and therefore it is not surprising that the outcomes are also long-standing. And I'll show you some data in a second. So I'm going to briefly talk about the BPD trends over time. You've heard a little from studies around the world from Dr. Onland's talk, but I just want to concentrate on what's been happening in Victoria, and I'll give you some idea about why I'm focusing on the cohort. And then I'll talk about long-term outcomes. I'll talk specifically about the pulmonary outcomes, not just respiratory health, but more specifically lung function and spirometry. I'll touch on neurodevelopment. It's not just about neurodevelopmental impairment, and I'll give you a bit of a flavor about what we look at in neurodevelopment when we look at long-term outcomes. And then very briefly, some work where we are also trying to see whether, depending on the different definitions of BPD that are floating around at the moment, whether there are differences in the longer-term outcomes, in particular both spirometry and childhood development. So you've already heard about the major advances in neonatal respiratory support and how a lot of that has contributed to the increased survival of the most immature and vulnerable of infants. But don't forget, it's not just about the respiratory support advancements, but it's also the willingness of individuals like yourselves working in the NICU who are prepared to offer intensive care to these infants. Because if you didn't, there's only one outcome, and that's death. So in the 70s, mechanical ventilation came about. I'm told by people who were practicing at the time, they didn't really know what they were doing. So if you wheeled out the mechanical ventilator, it was bad news. But then, as you've heard, we've gotten better at this. Then we had antenatal corticosteroids given to pregnant women at risk of preterm birth, surfactant, that magic milky substance, postnatal corticosteroids, which has had ups and downs, oxygen saturation targeting, which is also sort of big debate, and of course, non-invasive ventilation, the gentler modes of ventilation these days, and so on and so forth. I haven't mentioned caffeine, but there are lots of advancements. So in Victoria, we have been recruiting statewide population-based cohorts of every single infant born less than 28 weeks or less than 1,000 grams since the 70s. In these distinct years that you see there, so 6 cohorts, and with contemporaneous term controls, which is a very important study design in epidemiological studies because you need to compare with controls rather than just have a focus group, a preterm group, and rely on reference ranges, which may not be relevant to your population. So on the right, you see here the absolute numbers of survivors in Victoria over that time. And on the left, well, we've been more willing to offer active care, and therefore survival has increased. And that's when steroids came in, and that's when surfactant came in. I won't dwell on this slide. Dr. Onlen has given us a very detailed account of all the different definitions over time. And the reason why I put this up here is because of what's to come later on when you look at, when we try to look at some of the definitions of BPD and later childhood outcomes. Just to remind you, when you read a lot of the epidemiological follow-up population studies, the definitions of BPD have been very pragmatic and simple, and most of them have been supplemental oxygen and or respiratory support at 36 weeks post-menstrual age. So what are the trends over time? So a lot of the data I'm going to show you comes from the Victorian Infant Collaborative Study. This is a program of research that has existed in the state of Victoria, where I come from, since the late 70s, where the realization by Bill Kitchen, who you see here in the publication in The Lancet in the 80s, that as we got better at keeping these infants alive, it is equally as important to know what happens to them after they go home, because survival alone is not always the only outcome of interest. He also realized that you can't do things that well if you do it alone, not a single center study. So he brought together every single unit in Victoria providing intensive care to these babies. So 4 tertiary NICUs, now a 5th one, 6 cohorts to date, and over 2,000 babies in our program. You will see here all the cohorts and all the years of follow-up. We've seen many at 2 years at least, 5, 8, 14, 18, and 25 years. This has allowed us to look at trends over time. This has also allowed us to track these babies as they get older. So the 91-92 is the first post-surfactant era cohort. We last saw them at age 25. We're currently recruiting a new cohort. So what's happened in Victoria over 25 years? And this is very similar to what the previous speaker has shown you. But in Victoria, when we looked at our ventilation practices, this is observational, with median days on the y-axis, and we just concentrated on the extremely preterm. We didn't include the extremely low birth weight who were born greater than or equal to 28 weeks. So what did we find? So the median days of ET ventilation has dropped. We're using more CPAP. No surprises there. High flow was available only in the last cohort. And what did we see? It was additive. It didn't really take away the median days on CPAP. It was additive. So I leave it to you to speculate on how we in Victoria are using nasal high flow and whether that is reflective of your practices in your own units. Has this made a difference? Because of course non-invasive respiratory support is a major advancement in ventilation support. Has it decreased BPD? And not surprising, our BPD rates are steady. When we compare our findings with other cohorts, you can see here the NICHD, Epicure, and EPIPAGE, and I've concentrated on population cohorts that have assessed their populations at least 2 eras. So you can see the eras there, and in a nutshell, the rates for BPD in general are similar. However, there may be a hint for cohorts that did look at different grades of BPD that the severe BPD may have decreased. So it's not all bad news. For respiratory support and BPD trends, we've seen an increased consumption of respiratory support with more ventilation days and mostly contributed by non-invasive respiratory support. Overall BPD, as defined by 36 weeks oxygen, supplemental oxygen, or respiratory support, it's not decreased over time. However, there's a hint from some other population studies that severe BPD may have decreased, so we do have more work to do. So let's now shift to long-term outcomes. I'll start with the lungs. We're talking about the lungs anyway. So respiratory health first up. There are many studies that have reported long-term respiratory health following very preterm birth. So rehospitalization, respiratory health, and exercise tolerance. And when they've compared preterm children, this is not BPD or no BPD, just preterm children as a group compared with controls, it's not surprising that there's more rehospitalization. This is mostly in the first few years after discharge, and the hospitalization rates and the differences between preterm and term drop as they get older, and there's lovely data from the UK Millennium cohort. When you look at asthma or wheezing or even lung function with forced expiratory volume in 1 second, you'll see that the differences are greatest in the early years, certainly for asthma and wheezing, and that once again also drops off as the children get older. With lung function, and I'll show you more data in a second, the differences persist. And for studies that have looked at the functional aspects of lung function with exercise tolerance, there is limitation. All problems are worse if you look in the preterm group and compare those with or without BPD. It's accentuated. I now want to move to lung function. I know most of you are ventilation neonatologists. I'm not one of them. But one of our interests has been looking at lung function in childhood. So this is a graph well known to many of you. It's looking at the normal lung growth and trajectory. Our lung function peaks in the early 20s, so it's downhill from there, and it's certainly downhill for me. If you are preterm, there is now concern that you do not actually reach the peak that you would have if you were born full term. And even if the decline rate was similar, you potentially will end up having symptomatic chronic obstructive pulmonary disease at a much younger age than you would otherwise. And of course, if you do nasty things to your lungs like smoke and be born preterm, you can see the curve there. So spirometry, I'll just briefly go through, especially for those of you who are not familiar. So spirometry or lung function is a very objective way of looking at how the lung is. if the child is old enough to comply. And what do you have to do? So you're all sitting there, you're breathing quietly, so inhale, exhale. And then if you're doing a spirometry test, you're asked to take the biggest breath possible. And then blow out for 6 seconds. This is actually quite hard to do. And the reason why I highlight this is to show you how difficult it is to do in children. We've managed to successfully do that in 7- and 8-year-olds, but you do need very experienced pediatric respiratory technologists to help you. What do we measure? We measure the volume of expired air in 1 second, the FEV1. We measure the forced vital capacity and look at the ratio. We also look at the forced mid-expiratory flow, which is a very good indicator of small airways disease. A few years ago, Lex Doyle, you've heard the name a lot in this conference, and myself, we wrote a narrative review in seminars, and we looked at the impact of expiratory flow in preterm survivors and summarized the studies that were published at that stage. I just want you to concentrate on that black diamond and with FEV. So 0 is the line of no difference. Anything to the left means that you've got better FEV1 if you don't have BPD, and anything to the right sort of favors BPD. And you can see that the mean difference in FEV1 is about negative 0.75 of a standardized mean difference. It's not just a significant difference, but actually it's a clinically important difference. That's actually the more important message from this. A few years later, a group of us who are interested in adult outcomes following preterm birth pulled together data into this individual participant data meta-analysis. 11 studies, 935 preterms, and 722 controls, with a mean age of lung function assessment at 21 years. And what did we find for the groups when you compared preterms and controls? Not surprisingly, every single variable that was measured in spirometry was less optimal compared with term controls. We then looked at the perinatal and demographic predictors of FEV1, and you can see shining out there is bronchopulmonary dysplasia. So if you had BPD, you had worse. This is FEV1, but it was mirrored in all the other variables as well. So it's a very important predictor of later lung function, even in adult life. In the VIX 91-92 cohort, we were fortunate to have been able to measure lung function at 3 age points, 8 years, 18 years, and 25 years. And this data was published in Thorax in 2019. What we found, which was not surprising, was that the lung function variables were worse in the preterm group compared with controls. There was no improvement with age. When we looked at the subgroup with BPD versus not, what we did see here, and summarized in this bar graph, is the expiratory flows that were less than 5th centile. So this is a clinically important reduction in FEV1 at age 25 years. And you can see a stepwise reduction in this poor outcome, highest for those with BPD, a bit less for those without, and of course, a very tiny bar for the term controls. When we looked at the changes between 8, 18, and 25 years, I'll just walk you through that graph. So on the y-axis is the Z-score for FEV1. So this is, a standardized score against what's published in the Global Lung Initiative, standardized for sex, height, and also ethnicity. The gray line is for individuals with no BPD. They have better FEV1 Z-scores compared with those with BPD. But what was stark here was the changes with age. There was a slight worsening between 8 and 18, but fortunately it remained stable between 18 and 25. It will be very interesting to track these changes when these individuals reach their mid-30s, which is what we're hoping to do over the next few years. So in summary, with lung function, long-term lung function after preterm birth for those with BPD and without, those with BPD had reduced expiratory flows from school age. I haven't shown you the data, but the obstruction is fixed. They do not respond to bronchodilators. And within the preterm group, expiratory flows were worse with BPD, but fortunately, some evidence that the gap is not widening from late adolescence. What about neurodevelopmental outcomes? When we talk about neurodevelopmental outcomes, we look at several important domains. So one domain that we look at is cerebral palsy. And with sort of many studies that report cerebral palsy in childhood and older, the average rate is about 10 to 14% in population studies, less than 28 weeks overall. But if you do have BPD, the odds are increased by about 1.7. And of course, it's worse if you have severe BPD. Another assessment that we do are motor impairments, but non-cerebral palsy motor impairments. And here we can look at gross motor and fine motor outcomes. And what we did find from many of the studies, not surprisingly, they were all worse in the BPD preterm population compared without. And they were about 1 standard deviation lower, which is a clinically important difference. More were accessing early intervention services, and if you did receive postnatal corticosteroids to treat or prevent BPD, that was a risk factor for poorer motor outcomes. People do also report neurosensory outcomes, usually neurodevelopmental impairment, NDI, and BPD is an independent risk factors. As you get to school age and we can measure other outcomes like cognitive outcomes, IQ, academic performance, which includes reading, spelling, and mathematics computation, all these outcomes were worse in the preterms with BPD in the order of a clinically important difference. And finally, there are some studies, that report language delay, and children with BPD had more language delay. So that's to summarize the neurodevelopment. I just wanted to share some preliminary analyses with you. Now, these slides, please don't disseminate them because the data is unpublished. And similarly to the study performed in Amsterdam, we wanted to understand whether outcomes were different with different BPD definitions. So we delved into, these are the definitions revisited. We delved into our 2005 cohort because we did have 8-year outcomes. And with 2005, where we did have more non-invasive respiratory support use, only CPAP, not high flow, we looked to the 3 definitions. So we looked at the NICHD 2018, Alan Jobe 2001, and we modified the Jensen criterion because, as I said, we didn't use high flow then and called it the VIX 2005 for want of a better term. When we looked at the incidence with the different definitions, so this is on 218 survivors at 8 years, not 2 years, 8 years. So with the BPD definitions, you can see here in the blue bar, the rates are higher depending if you use the more recent definitions compared with the one in 2001. But you also had less of the severe BPD in the more recent definitions compared with the earlier definitions. So the incidence was different depending on which definition you use, and that goes back to the problem that Dr. Onland highlighted for studies. We looked at the spirometry outcome, so this is ZFEV1 less than the 5th centile. And when we looked at those 3 different definitions, with Alan Jobe's definition, so severe BPD had a higher rate of this poor FEV1 less than 5th centile compared with no BPD, but the other severity grades were not discriminatory. The message was a little bit different with the more recent definitions where the different levels of BPD were significantly different compared with no BPD, and this is lung function at 8 years. We also attempted to look at major disability at age, and I guess our populations are slightly different, of course, to the Amsterdam cohort, but what we also found was a similar message, less discriminatory with the earlier definition, slightly more with the newer ones, and this work is ongoing as we look at other outcomes that we have at 8 years. So I'd like to just finalize my talk with some key points. We do know that BPD is an important morbidity after preterm birth. The rates are the highest in the most immature and unfortunately not decreasing despite advances in care. BPD is an important risk factor for poor pulmonary and neurodevelopmental outcomes to school age and actually even beyond. And the associations with outcome differ depending on the BPD definitions. Now, for those of you who have children who've gone on long drives, I'm sure in whatever language they speak, you often ask the question, are we there yet? Are we there yet? So there's this lovely children's book written by Alison Lester, which most Australian children would have read, and the title, very fittingly, Are We There Yet? And I think for BPD, I'm afraid we're not. But we're making positive steps, I'm sure. I've presented a lot of the data from decades of work from the Victorian Infant Collaborative Study Group. I also want to acknowledge Lex Doyle for his immense contribution in this area. I'm happy to take questions. Thank you very much.
Thank you very much for this excellent talk. We have time for probably one question. Okay, while people are thinking, if I may just ask quickly, you have seen the 25-year spectrum in this. The practices have changed over a period of time. How do we incorporate that in the conclusions?
I think that is always the issue with longitudinal studies. By the time you get by the time you get an 8-year answer, practices have changed over 8 years. So I think all I can say is that based on the post-surfactant era, we haven't seen any improvement. Mind you, these people are surviving, they are becoming adults, and it's important that we inform our adult colleagues as to the morbidity. So that's at that end in terms of their longer-term health. How we go back to think about how this reflects in the newborn care, I think all we can do is look at the associations with the changes in care and what's happened. So yes, 91, 92, we were using far more invasive ventilation. We didn't have as much surfactant. We didn't have the rates of antenatal corticosteroids weren't as high. But if we look at how things have changed, certainly in Victoria over that time, and even 2016, 2017, we haven't seen a lot of movement with, say, BPD, however it's defined. We've seen a little bit of improvement at 2 years in the latest cohorts, but back in 2017, we published a whole series of papers looking at various outcomes at 8 years. Between 91, 92, and 2005, we didn't see any improvement, so we were very disappointed. We're sort of hoping that the tide will change as the 2016 cohort become 8, and that's next year. But I think we can just sort of, for me, the main message is we're not there yet. We can't rest on our laurels, steroids, surfactant, non-invasive ventilation. We haven't gotten rid of BPD. We've got lots more work to do.
Thank you very much. I have a pleasure inviting a good friend, Dr. Anna Levizzari from Milan, Italy. She is a very active neonatologist, also holding positions in the European Respiratory Society and in the editorial board of the journals. There is not enough time to introduce her, so I better start with your talk. So Anna, all yours.
Thank you very much for the nice introduction, and I want also to thank Peter for giving me such an interesting title for something's wrong with the presentation? I was saying I want to thank Peter for the intriguing title that he gave to me, but I also have to admit that it was a bit challenging, and I will try to explain you why, if the slides arrive. Okay, fine. So, to simplify this title, I tried to split the problem into different parts. First of all, I tried to answer to the question, why should we perform a respiratory follow-up for our preterm infants? Then I tried to answer to the question if we should focus on infants with a diagnosis of BPD, or if we should also think about the one who has not a diagnosis of BPD, and Professor Cheung already answered to this question. Also, we need to understand which are the available tools to diagnose and follow up those infants. And finally, I put together some future steps in this field. So if we look at this graph, this represents the possible trajectory of lung function expressed as percentage of predicted peak of lung function. The green line represents the lung function of normal subject, meaning that lung function improve over time, reach a peak between 20 and 25 years of age, and then after 50 years of age, we can see a slight decline. There are then subjects who are supranormal, for instance, some athletes, but there are also subjects who start at the lower trajectory. But there are also opportunities from moving from one trajectory to another, for instance, through catch-up growth, and unfortunately, sometimes also because of an early decline or premature death. So what determines where a certain subject is on this trajectory at the given time point? We can explain this through the so-called getomics approach, which was theorized by Professor Alvaragusti to explain the complex pathobiology of COPD. Meaning that where a certain subject is at a given time point depend from the complex interaction between genetics and environment over time exposure, meaning that the cumulative history of the subject counts and have an effect for the future phytophysiological responses. So going back to our graph, where do we think are our preterm infants? Our preterm infants are born at a premature age, meaning that they underwent a premature arrest of lung growth. Also, we know that they are exposed to an hostile environment in utero, for instance, because of chorioamnionitis or maternal smoking. During the NICU stay, we further expose them to hostile environments, such as because of high oxygen concentration, mechanical ventilation, infection, poor nutrition. And we also know that during the first few years of life, they are more prone to develop respiratory infection. Further on, they may be also exposed to other toxic risk factors. So we think that all these factors may push their trajectory towards the bottom line. But is it true? And also, if there is the opportunity to deviate those trajectory, how we can early detect this deviation? I think that this is probably the role of the follow-up. Then the second part of the question was about following only infants with a diagnosis of BPD, or also infants without a diagnosis of BPD. Professor Ginny Cheung already made my job easier because we have no doubts that we need to follow up infants with BPD. We know that they are at a higher risk of respiratory sequelae in the first few years of life, higher risk of hospitalization, higher need of oxygen, home oxygen, or even home ventilation, higher risk of requiring inhaled medication, and risk also of tracheostomy, which is increasing with increasing severity of the disease. And she already explained in her fabulous presentation all the possible complications of infants with BPD that are beyond the respiratory field. But what about infants without a diagnosis of BPD? If we look at the data reported into the literature, we can see that during the first year of life, they are at increased risk of hospitalization, which raise up to 50% in those with BPD. They have an increased risk of wheezing and of using inhaled medication. This risk of wheeze persists at the age of 5 years of age, and this is independent from the BPD definition, from the diagnosis of BPD. And even further on, during school age, they present an increased exercise-induced respiratory symptoms, increased risk of asthma diagnosis, and increased risk of requiring inhaled medication. And this risk persists as compared to the term counterparts until adolescence. What about the trajectories? This is a very robust study, also from Australia, from the Western Australia group. Was a study assessing lung function over time with at least 2 time points in early childhood between 4 and 8 years of age, and 1 assessment between 9 and 12 years of age. They applied different lung function testing, and they included in the study 200 very preterm infants, 120 with a diagnosis of BPD, and about 70 infants, term infants with an healthy lung. What we can see from this graph that report the predicted spirometric parameters over time is that both infants with BPD, which are represented by the solid line, and infants without BPD present a decline over time in their lung function. And this decline was more marked in those presenting inflammation sign at the CT scan or exposed to cigarette smoking. What about adolescents? This was already presented. We know that between 8 and 18 years of age, FEV1 decline in those infants. This is more marked again in those with BPD and also in those exposed to smoking. Let's go to adulthood. This is a huge cohort study from the Scandinavian country. They included patients both from Finland and Norway. Patients from Finland were born between 1987 and 1998. Those in Norway between 1967 and 1999. And they actually found that the risk of developing obstructive airway disease was 2 to 3-fold higher in those born below 28 weeks of gestation and between 28 and 31 weeks of gestation, and the risk decreased with increasing gestational age. There were no difference between the 2 cohorts, Finnish and Norwegian, and not even differences at the time of assessment below 30 years of age or between 30 and 50 years of age. But when they looked at the diagnosis of COPD, the odd ratio was 7.4 for those born below 28 weeks of gestation, 3 for those who were born between 28 and 31 weeks of gestation, and 2.3 for those born between 32 and 33 weeks of gestation. Again, looking at the data coming from adulthood, this is a large cohort study, once more from Australia, from Tasmania, that shows that the risk of COPD is significantly higher in infants born preterm as compared to the term counterparts. And again, once more, outcomes are worse, in particular in terms of a ratio between FEV1 and FEVC in those who are smoker at the time of assessment. What about the tools for diagnosing those infants? So we know from preclinical studies and also for the few physiological assessments that we perform in the NICU that infants with BPD present both structural and functional alterations. So how we can capture those alterations after discharge? This is again a study from Australia, from Shannon Simpson. She studied 58 controls, health terms controls, and 116 preterm infants who underwent both a CT scan between 9 and 11 years of age and functional spirometry. And they actually found that 92% of the preterm infants were presenting with alteration at the CT scan. And those were, of course, once more significantly higher in the BPD group. For each single week of gestational age, the CT score decreased by 0.64. And there were also a strong correlation between the obstructive pattern at the spirometry and the structural changes at the CT scan. But what happens later in life? What happens at 20 years of life? This is another study from Western Australia, exploring the outcome at the CT scan of a cohort of 51 adults born between 1980 and 1988. The vast majority of them presented alteration at the CT scan, and interestingly, about 50% were presenting with emphysema. But of course, one limitation of this study that has already been mentioned is that this cohort does not reflect the actual babies that we are treating in our NICU, meaning that those babies were born in an era where surfactant was not available and even postnatal steroids were not commonly given. For sure, if we want to follow up those infants over time and capture their structural alteration, CT scan might not be the best choice because of the exposure to ionizing radiation. These colleagues from Maastricht developed a protocol for applying MRI to capture lung changes, and they were actually able to demonstrate in a cohort of infants, both preterm with and without BPD, compared to control, that they presented architectural disruption at the MRI. Also, they were presenting with defects in terms of ventilation and perfusion by applying the Fourier decomposition. An important remark of this study is that this protocol was feasible and also was safely applied to all the preterm infants. So we may think about this technology to follow up them over time. What about lung function? A lot of these data were already presented. We know that for sure spirometry is one of the best well-established methods to assess the lung function. It is spread all over the world. We know for our preterm infants that their FEV1 with and without diagnosis of BPD is lower, about -9%. And for those with BPD diagnosis is about -15%. But this large systematic review included also all the very preterm infants. What about those who are born moderate to late preterm? Again, the differences in FEV1 as compared to the term control were significant, were maybe modest, but we should address this issue to our colleague from the Department of Adult Pulmonology, because they are still at an increased risk of developing or evolving towards COPD. However, spirometry is not easily applicable in infants before preschool age. School age. And so one tools that we could apply is the tidal breathing flow volume loop. Tidal breathing flow volume loop also has been standardized by the ATS and the European Respiratory Society. It is easy to apply, does not require the cooperation of the patient, and can be performed without sedation. And also is a useful tool for identifying obstructive patterns at the lung function. We are applying actually this technique in our preterm infants, in infants that we follow up in our unit, and we were able to characterize the trajectory of tidal breathing flow volume loop over the first 2 years of life. In particular, we focus on the obstructive parameters of TPTFA on TE, and we demonstrated that these remain below normality in the first 2 years of life. Also, it correlates with the main risk factor during the NICU stay, oxygen supplementation, time spent on mechanical ventilation, and overall duration of non-invasive respiratory support. And also, we were able to demonstrate that TPTFA on T at 2 years of, in the first few months of age can predict the risk of rehospitalization and wheeze. Another technique of lung function that can be easily applied in non-cooperative infants is the forced oscillation technique. And the colleague from the University of Western Australia applied this technique to a cohort of about 50 infants with mean gestational age 26, between 3 and 6 years of age. And they demonstrated that these infants present a higher respiratory reactance and a lower respiratory higher resistance and lower respiratory reactance. So if for some lung function testing the results were almost all in the same direction, for other lung function testing we have to admit that the results were mixed, and this might have been due to different population, but also because of heterogeneity of the methods applied. What about treating these infants? From the systematic review by Sara Koteka, we know that some of these infants, about 30%, are responding to bronchodilation, but we don't know what are the long-term effects of this treatment. So the ATS recommend not to use a bronchodilator in infants who do not present recurrent wheezing, and we can use bronchodilation in those infants who present recurrent wheezing or cough, performing a short-term trial by monitoring the clinical response. Similar approach for the inhaled corticosteroids, so not recommended for those who not present recurrent cough or wheezing, and a short trial for those who present those symptoms. But these recommendations were published before this randomized control trial. This was a randomized control trial enrolling school-age children that at randomization were presenting with an FEV1 below 85%. There were two possible interventions. One was the administration of inhaled steroids for 12 weeks. A second possible intervention was the combination of inhaled corticosteroids and long-acting beta-2 agonist as compared to placebo. And the main outcome were the improvement at the spirometry and at the exercise capacity. And they actually found that in both the treatment group, there was an improvement in lung function, plus 7% in those treated only with inhaled corticosteroids, and plus 14% in those treated with both the drugs. So, going to conclusion, we know that our preterm infants present respiratory symptoms, present alteration both in lung function and structure. We know that those alterations, clinical, structural, and functional, are more pronounced in those with BPD, but not necessarily only in these infants. And we also know that other than presenting a lower lung function, they may move towards an earlier decline in their lung function. We know that we have some tools for monitoring them, both imaging and lung function testing tools, in order to early detect the possible changes in their trajectory. However, we do not know exactly who for, so we don't know what are the best techniques to monitor them, and particularly the calendar for doing that. We do not know yet in detail the underlying mechanism of inflammation after discharge from the NICU. We do not know who and how to treat them, and also another important question is if we can somehow manipulate the complex process of lung injury and repair in order to promote lung function. And finally, it might be a bit obvious, but if we still have a lot of questions, we also know from the study on COPD that what we can for sure do is to applying preventive strategy, meaning that we can apply all the preventive strategies that are commonly recommended to prevent COPD, meaning that our infants should limit the exposure to toxic, pollutant, or tobacco. We should avoid infection, promoting and encouraging vaccination and RSV prophylaxis. We should also promote an healthy lung development by encouraging physical exercise, adequate nutrition, a timely diagnosis of asthma, and the proper management of the problem. So thank you very much, and I'm open for a question.
Thank you, Anna, for a very nice talk. Yeah, please go ahead.
I have to disclose that I'm a ventilation neonatologist and not an expert in follow-up, but I'm increasingly collaborating with my colleague of the follow-up department, and I think that this is very fruitful for both of us.
We have time for one quick question. Okay, just to ask that, based on your follow-up data, is there a difference in the BPD phenotypes that you would come out with? That is it possible?
So it is, let's say that it is still very difficult. We do not know yet how to exactly phenotyping those infants. So based on the data that we collected so far, I cannot make definitive conclusion, but in Italy we are trying to organize, on the example taken from other country, a more structured follow-up. But again, I think that there is still a need of identifying the best diagnostic tools for doing that, which must be, of course, also doable and economically acceptable, sustainable.
Well, thank you very much. And let's thank all the speakers for an excellent session. And thank you all for staying back.